Okay, good evening everyone, and thank you for joining us tonight for our event Set Up for Life, which is part of this year's Cambridge Festival. So this is a joint event between Horizons, which is our university's research magazine, and the Reproduction and Strategic Research Initiative, which brings together researchers from many disciplines across the university to explore the challenges posed by reproduction today. So we have three fantastic speakers here with us tonight. Each speaker is going to talk about their area of research for about 15 to 20 minutes. Then when everyone's finished, we'll open it up to questions from the audience. If you've got a question, then please use the Q&A function to send it to us. Please let us know if it's directed at a particular speaker. So we're due to wrap up at 7:45. If we have lots of questions, we may be able to just keep it going a little while longer. So the event's being recorded and live streamed on YouTube, but only the speakers will appear. So with that, I'm going to hand over to our first speaker, who is Professor Dino Giussani from the Department of Physiology, Development and Neuroscience.
Well, thank you, Craig. Good evening, ladies and gentlemen, from my lovely afternoon at the University of Cambridge. So what I am to do over the next 20 minutes or so is to tell you about heart disease and how we may be able to protect the heart health of children across generations. Now, my research group is interested in cardiovascular disease quite simply, of course, because this is the greatest killer in the world today. So in this map, we can see that every country that is colored in pink has heart disease as its greatest prevalence. So it's bypassed cancer by several orders of magnitude, for instance. So it's easy to see how cardiovascular disease really imposes a significant burden on every nation's health and wealth. So it is clearly an important as well as an expensive problem to resolve. Now, the first thing that comes to our mind, of course, when we think about cardiovascular disease is this gene-environment interaction. That is to say, of course, how our genetic makeup interacts with traditional lifestyle risk factors such as smoking, obesity, or a sedentary life to set a risk of cardiovascular disease. However, now we understand that the gene-environment interaction before birth may be just as, if not more important in setting a risk of cardiovascular disease. That is to say, how the genetic makeup of the unborn baby may interact with adverse conditions during pregnancy, in complicated pregnancy, to set a risk of cardiovascular disease. And this is known as the field of developmental programming of health and disease, and it's been introduced into medicine by the wonderful physician, Dr. David Barker from the University of Southampton. And to me, developmental programming makes a huge amount of sense because, of course, our biology, what makes us function is so much more plastic and malleable during early life. And in fact, it's a law of nature, isn't it? That the younger we are, the greater the impact the environment has upon us. And if you think about this, this really has its maximal expression during fetal or embryonic life, and it diminishes progressively as we grow older. So a challenge to the cardiovascular system, to the fetus, perhaps only lasting a few minutes, may be equivalent to the damage done over years, if not decades, in later life. And quite a depressing graph, I think, is that the opportunity for correction follows a similar trajectory, being greatest in early life and diminishing progressively as we grow older. And I say depressive because although I can't see you, I imagine that most of us are, of course, like me, are to the right of this slide. So for us, it is too late. The die has been cast, if you like, or the toast has been burnt. And of course, we can't unburn the toast, but what I suggest to you we can do is to make a better job of the next slice, to make a better job of the next generation. So I think in medicine today, I think in public health today, there is a change in perspective from treatment when we can do comparatively little about heart disease to prevention, of course, when we can do comparatively a lot. And clearly there is no better form of preventative medicine than bringing this right back along the developmental trajectory and halt the onset of disease at its very origin, if possible, to bring preventative medicine back into the womb. So in this field of science, what we're interested in is how adverse conditions during pregnancy may program a future risk of cardiovascular disease, and if so, via what mechanisms. So of course we can do something about it. We can design some interventional strategies. Now, one of the most common adverse conditions during pregnancy are chronic reductions in fetal oxygenation, what we call chronic fetal hypoxia. And in essence, this occurs in complicated pregnancy where there's a problem with the placenta that reduces blood flow to the fetus and of course decreases oxygen delivery. And this may happen in pregnancy complicated by fetal growth restriction or chorioamnionitis, placental infection, for instance. But it's also quite important to highlight that chronic hypoxia can happen in inflammatory conditions, quite topical today, such as our gestational diabetes and maternal obesity. And hypoxic pregnancy is important because now we know that it has been shown to program heart disease in the adult offspring. And this comes from evidence derived from clinical studies, for instance, from the studies of Paul Leeson at the University of Oxford, whose group has shown that adult men and women who were born from pregnancies affected by fetal growth restriction are at greater risk of cardiovascular disease. Of course, in preclinical animal models where we can study things in greater detail, we and others have also shown that hypoxic pregnancy in laboratory rats and mice, for instance, programs heart disease in the adult offspring. But it's not all doom and gloom, because last year, for instance, we showed in another preclinical animal model in ovine pregnancy that we can treat the mothers with mitochondria-targeted drugs, and this seems to protect the adult offspring from cardiovascular disease. So what seems to happen is that pregnancy affected by fetal hypoxia causes a condition that some of you may have heard of known as oxidative stress in the placenta and in the developing cardiovascular system in the fetus. And oxidative stress, of course, is when free radicals, these really reactive molecules, interact and attack with the cell, and they are generated during hypoxic conditions and can start attacking the developing cell. And if that's a cell from a placenta or from the developing heart and circulation, it is easy to see how this may emerge later on as an increased risk of cardiovascular disease in later life, cardiovascular problems in later life. Now, it seems that within a cell, oxidative stress is generated in these tiny little organelles called the mitochondria that, when blown up, look like this. And oxidative stress occurs primarily then within the mitochondria of a cell. So most recently, we joined forces with Professor Mike Murphy, who's a mitochondrial biology expert. And Mike is one of these hyper clever people at the University of Cambridge who designs mitochondrial therapies for a living, if you like. So most recently, he designed a molecule called MitoQ that is able to internalize itself within the mitochondria to protect against oxidative stress. So in a recent experiment, we thought with Mike that we would blast oxidative stress in complicated pregnancy, for instance, pregnancy complicated by chronic fetal hypoxia. So what we did was to study two groups of pregnancies in sheep, one undergoing normal, healthy pregnancy and one undergoing hypoxic pregnancy. And what we did was to treat half of them, half of each group, with MitoQ, which was given to the mother. Now, the other thing that we can do at the University of Cambridge is allow these pregnancies to be born and raise the offspring to adulthood under normal conditions, because we have paddocks, grassland that belongs to the University of Cambridge. So we can bring these cohorts to adulthood, early adulthood, which for a sheep is about 9 months, which is the equivalent to about a 25 to a 30-year-old human. And then what we can do is study their cardiovascular system as adult offspring of either control or hypoxic pregnancy, treated or untreated with this drug. And this is what we published last year. What Kim, Kirsty, and Katie are showing here is measuring the blood pressure of this adult offspring over long periods of over days. And what they can show is that adult offspring of hypoxic pregnancy, which is the black histogram here, have an elevated blood pressure compared to the control pregnancy, which is the white histogram. So this proves that developmental hypoxia can program a future risk of high blood pressure or hypertension in later life. Interestingly, maternal treatment with MITO-Q in hypoxic pregnancy, which is the red histogram, protects against this, and MITO-Q treatment in controlled pregnancy, which is the blue histogram, does not have any effect. And now we started looking at the aortas, for instance, of these animals for indices of fibrosis and scarring, which is of course related to atherosclerosis, which is again a condition you may have heard of, which is related to cardiovascular disease. And in essence, the greater the red in the aorta, the greater the incidence of fibrosis and scarring, which again we can quantify. And this shows that prenatal hypoxia can again promote an increase, program a future increase in aortic fibrosis and scarring, an index of atherosclerosis. And again, we can protect this with maternal treatment with MITO-Q. So what I have shown you then is that the risk of heart disease can indeed begin before we're born, that the environment of our earliest months in the womb can affect our long-term heart health, but excitingly, mitochondrial therapies may be able to protect our children from high-risk pregnancies. So in the last 5 minutes, what I wanted to do was to expand this concept to a concept that is really effervescing in this field, which is known as intergenerational programming, or the 100-year effect. And without question, to me, this really has the greatest impact, the farthest reaching implications for our health that we never really envisaged, nor we really imagined. Because it appears now that the health of our children may depend on not only the experience their parents had in the womb, but also on the experience their grandparents had in the womb. And fascinatingly, the risk of heart disease appears to differ if their father or their mother experienced hypoxia in fetal life. So this is the intergenerational inheritance of traits science. And what we know in this science is that the parental environment can influence the offspring well-being by both paternal and maternal lines. And to everyone who's a parent here, perhaps that's an obvious statement in the way that we bring up our children. But the interesting thing is that this not only applies to behavioral traits, but also to biological or physiological traits. However, the mechanism of this intergenerational transmission of biological traits really remains poorly understood, even though there is absolutely mounting evidence for its existence, mounting evidence from studies such as the one that I'm going to show you next, which we did last year, which exemplifies some of these ideas. So here what we did was to work with laboratory rats, and we generated a female offspring from a pregnancy that when she grew up, she mated to become a mother, but she underwent a hypoxic pregnancy. So in essence, she generated male and female offspring from hypoxic pregnancy. And then these offspring, when they grew up, we mated them to create a second generation, grandchildren, if you like. So male and female offspring whose father was exposed to hypoxia in utero, or male and female offspring whose mother was exposed to hypoxia in utero. And what we reasoned was that the germ cells, i.e. the sperm of this male that developed under hypoxic conditions as a fetus during its hypoxic mother, during its own development, would have some memory of this discomfort and be able to transmit information to the second generation. And likewise, these germ cells of this female, i.e. the mature eggs or the oocytes that again developed under hypoxic conditions as a fetus during its mother's hypoxic pregnancy, would also retain some of memory of this discomfort and be able to transmit this to the next generation. And what we found was absolutely fascinating, because what we found is that during hypoxic development, harmful changes occur in sperm that actually can increase the risk of heart disease in the offspring. And of course, these harmful changes are present in the sperm of this male that he can then transmit onto his children. But in contrast, what we found is that with females in the mature oocytes, we found that during hypoxic development, they develop beneficial changes in their oocytes that can develop a protection against heart disease. And that's because the oocytes contain hundreds of thousands of mitochondria that can actually acquire protective traits for cardiovascular disease. And of course, these protective mitochondria are present in this female. And of course, she could transmit this protection to the next generation. So it's a wonderful legacy to leave onto children. So it appears that while a father who was hypoxic in utero can transmit a risk of heart disease, a mother who was hypoxic in utero can transmit protection against a future, for instance, heart attack in her children. So I know that these concepts are quite difficult to teach, particularly in a short period of time. So I wanted to leave you with something more palpable that you can actually remember and take home, if you like. And I thought the best way to do this was to introduce you to my daughter. So this is Gabriela, who was 7 years old during this picture. And you can see that, of course, we had a lot of fun trying to update this particular photograph. And of course, her postnatal environment would have shaped some of her biology and physiology. But really what I've told you in this seminar is that most of her biology and physiology would have been programmed by the quality of her own fetal environment while in my wife's womb during my wife's pregnancy. And that quality of the environment would have shaped not only the health of her heart and circulation, and also the health of her brain and cognitive capacity, but also, of course, the quality of the eggs and oocytes in Gabriela's ovaries. Now, unfortunately, I know that Gabriela will grow up one day to be an adult, but when she does, I very much hope that she has children of her own. So you see, ladies and gentlemen, it would appear then that the quality of my wife's pregnancy will therefore not only influence the health of my daughter, but also the health of my grandchildren, and hence why we call this the 100-year effect. So I think in medicine today, I think in public health today, we have a truly wonderful opportunity to do something that is extraordinary and unique. And that is to be able to influence the heart health, not only of our children, but also their children, and of course, their children's children. And I would love to continue being involved in this field of science. So lastly, I'd just like to thank past and current members of my laboratory at the University of Cambridge at the Barcroft Centre. It's only because of them that, of course, work like this can actually happen. And I also like to acknowledge the sources of funding for our work, highlight the contribution of the British Heart Foundation, who has funded our work for the last 20 years. Thank you for your attention.
That's great. Thank you very much, Dino. That was kind of really fascinating. So we're now going to hand over to our second speaker, who is Professor Sue Ozanne from the Wellcome-MRC Institute of Metabolic Science.
Thank you very much, Craig. And so I want to build on what Dino's described and show you that in addition to hypoxia, exposure to a suboptimal nutritional environment as a growing fetus can also impact on our long-term health. And that that's not just in relation to heart disease, but also in relation to type 2 diabetes. So like heart disease, type 2 diabetes is a global problem and affects many populations in the world. It is also a problem that is increasing at an alarming rate. So there's over 400 million people across the globe who've been currently diagnosed with diabetes. And of these, over 3 million of them will currently live in the UK. Now, in addition to those who've been diagnosed with diabetes, we also know that probably there's about 1 million people in the UK who are unaware that they have diabetes. And so just like in the rest of the world, cases are growing in the UK, and it's thought that by 2025, there will be over 5 million people who who currently have diabetes in the UK alone. Now, there's various forms of diabetes. They all, in essence, mean an inability to regulate our blood glucose level. But 90% of diabetes is what we call type 2 diabetes. And this is traditionally adult onset, though is actually increasingly becoming apparent in the younger population. Now, type 2 diabetes is a complex disease, so not just due to one factor. So there's multiple factors that contribute to our risk of developing type 2 diabetes. These include our genes, and scientists have identified a number of genes which increase our risk of developing type 2 diabetes. It's a condition that's very much associated with age. So as we get older, we're more likely to develop type 2 diabetes. Smoking also increases our risk of type 2 diabetes. Obesity is a major risk factor for type 2 diabetes. And so the increasing prevalence of type 2 diabetes really goes hand in hand with the increased prevalence of obesity. And in addition, we know that reduced physical activity and a poor diet can also impact our risk. Now, we obviously know that what we eat will impact on our health. I think most people can understand that concept, that what we eat will impact on our current health. But in the context of today's talk, it's also important to highlight that what we eat as a growing fetus, or what nutrition we're exposed to as a growing fetus, will also have these so-called programmed effects on long-term health. And as Dino mentioned, this is what's been termed developmental programming. So Dino showed you the evidence for suboptimal oxygenation to the fetus impacting on long-term risk. I'm going to focus on the impact of undernutrition in utero. And so we know that undernutrition in utero will impact on the structure and function of our organs and how well we grow. So one of the indicators of suboptimal nutrition in utero as a growing fetus is a reduction in birth weight. And this is really where the first evidence in this field came that really led us to believe that nutrition as a fetus will impact on our long-term health. And this was work, as Dino mentioned, that was pioneered by David Barker, who was living in Southampton at that time. But he capitalized on observations that actually in the early part of the last century, most babies were not born in hospital, they were born at home. And they were visited frequently by health visitors and midwives after their birth. Now, some very forward-thinking midwives in Hertfordshire, not far from Cambridge here, in the UK, actually were very pioneering, and that they kept these incredibly detailed records of the baby's birth weight and other features of that baby when they visited them almost once a month in the first year of their life. And so this next slide here shows you an example of those very detailed birth weight records that were kept. And David Barker tracked these birth weight records down and then identified the individuals to whom these birth weight records related to. And at that point, these individuals were in their mid-60s. So what David did in collaboration with Nick Hales here in Cambridge was look to see these men for whom they knew their birth weights, was there any relationship of birth weight to their current prevalence of diabetes? And so what David and Nick observed was that those men who were smallest at birth were much more likely to currently have diabetes or a pre-diabetic, what we call impaired glucose tolerance, than those men who were heaviest at birth. And this was very much linear across all the birth weight categories, so not something just relevant to very small birth weight babies. And if you look at the relative risk from going from the highest birth weight category to the lowest birth weight category, you can see that that's over a 5-fold increased risk. So the men that were less than 5.5 pounds at birth were 5 times more likely to have diabetes or be pre-diabetic in their 60s than those men who were heaviest at birth. Now, epidemiological studies such as this one show you associations and doesn't tell you what the cause of this relationship is. So clearly there's a number of factors that can influence our birth weight. There'll be genetic factors that can influence our birth weight. But David Bark wanted to ask the question, are there environmental factors that link and cause these differences in birth weight? Now, really to tease out effects of the environment in genes on all kinds of diseases, one useful tool to do this is to look at identical twins, because obviously identical twins start from the same fertilized egg and often share a placenta and therefore have the same genes. They have the same genetic makeup. So what a group headed by Alan Vag in Denmark did was looked for identical twins living in Denmark who were in their 60s, but where one twin had type 2 diabetes and the other one didn't. In Denmark, they have exceptionally good birth weight records. So he was then able to look to see whether there was any difference in birth weight between identical twins where one had diabetes and the other one didn't, between those two twins. And so what he observed was that the diabetic twin on average had a lower birth weight than their non-diabetic identical twin brother or sister. Now, although these identical twins share a placenta, they often don't share it equally. And so therefore, this difference in birth weight is likely related to differences in the environment to which they're exposed as a growing fetus. Their genes are identical, so it's not due to different genes. So that shows you that this relationship between birth weight and type 2 diabetes holds true in genetically identical individuals. So that's very supportive of the environment as the fetus impacting on our long-term risk of type 2 diabetes. Now, to address further whether this is due to differences in nutrition, that's very difficult to do in a human context, because obviously you can't change the diet of a woman, and actually what a woman is eating during pregnancy, or for anybody's eating at any time point, it's very difficult to get very accurate records of nutritional intake. So really to address whether there's any impact on nutrition and undernutrition during pregnancy on long-term health, what people have to do is make use of situations where, for whatever reason, there's been a period of famine. And one example of that is the Dutch hunger winter. So this occurred at the end of World War II, when there were very strict official rations to this region of the Netherlands because food supplies were cut off. So the official rations were only in the region of 400 to 800 calories per day. Now, because this was a short, defined period of famine, as soon as the war ended, food supplies returned to normal, it was possible for this group in the Netherlands to trace individuals when they were in their 50s who'd been exposed to this famine when they were growing fetuses, and look to see whether they were more likely to have diabetes now when they were in their 50s compared to people who were born either the year before the famine or the year after the famine, when the nourishment of this population was normal. And what this group demonstrated was that those individuals who were a growing fetus during the famine had both reduced birth weight and were more likely to be pre-diabetic or have diabetes when they were age 50. Now, what this study of this so-called Dutch famine cohort also showed very clearly was how multiple risk factors can add together to increase risk of type 2 diabetes. So as I mentioned before, obesity is a major risk factor for type 2 diabetes. And in humans, we can measure our adiposity by our body mass index, which is our weight in kilograms divided by our height in meters squared. And so if you look at individuals, both those born the year before the famine and those who were growing fetuses during the famine, you can see that as they become fatter as adults, these values here are glucose measurements after the person's had a sugary drink. And you can see the glucose level is much higher the fatter the individuals are as adults. But as you can see, at each current body mass index category, those who are a fetus during the famine have a higher blood sugar level than those of equivalent adiposity who were born the year before the famine. So the highest blood glucose of all is seen in these people here who were undernourished as a growing fetus and are now obese as an adult. You can also see the real protective effect in those individuals who remained lean. Now, if we want to understand how and why nutrition in utero can impact on our long-term health, we really need to understand, well, how does the body normally regulate blood glucose levels? And so we understand quite well how the body does this. Now, sorry to show you a nice tasty piece of cake, which if like me is dinner time and you're getting a little bit hungry. But when we know we eat a nice piece of cake, that leads to the glucose levels in our blood increasing. That increase in glucose is detected by our pancreas. And in response to that, our pancreas will produce insulin into the circulation, into the blood. So the insulin then circulates around the body and really talks to three main tissues and three main organs in the body. That's our liver, our muscle, and our fat. So the insulin tells the liver to stop releasing glucose into our blood, and it tells our muscle and fat cells to take up glucose out of the circulation into the cells. And so the consequence is that our blood glucose levels, our blood sugar levels will go back to a normal level. Now, we've also been able to do very detailed studies over the last 30 years by many different groups across the globe. This is really an international science, as sciences in general, to really understand in much more detail what are the proteins involved and how does the fat cell and the muscle cell know that insulin levels are increased and therefore those cells need to take up more glucose. So we know in great detail that when glucose levels increase in the blood, as I mentioned, that tells the pancreas to release insulin. Now, the insulin doesn't go inside the muscle and fat cell, but binds to a protein on the cell surface called the insulin receptor. This then activates a cascade of events. It's like a long telephone line where this protein will then talk to this protein, which will talk to this protein. And so that's a whole signaling cascade. Now, the protein inside the cell at the very end of the cascade are these proteins here, which are glucose transporters, which, when the insulin has bound to the receptor and activated all these proteins, the ultimate outcome is that it tells these glucose transporter proteins to move to the cell surface, and they therefore allow glucose to go into the cell. So we know exactly which genes and proteins allow the cell to do this, and in the laboratory, we can measure these proteins in tissue samples. So what we did in my laboratory was to work with a group in Denmark where we could recruit Danish men from the National Danish Birth Registry who either had an average birth weight or had a low birth weight. Now, these individuals are by all intents and purposes healthy, lean, fit individuals. But you can see even at the young age of 19, they're not diabetic, but they already have very slightly increased glucose levels in their blood, which suggests that their body's not working effectively to regulate the blood glucose level. So to try and understand why this may be, we took fat biopsy samples from these individuals by inserting a small needle into their abdomen. And then we measured all those proteins that I showed you on the last slide, which we know are required to stimulate glucose uptake. And when we looked at how much of those different proteins there were in the fat cells, we can see that the low birth weight individuals had a lower level of that glucose transporter protein. So they only had about half the amount of glucose transporter protein. And they also had lower levels of those other proteins, which are in that telephone line telling the glucose transporters to move to the plasma membrane. So we think that it's a reduction in these proteins which explains why these individuals already have increased glucose in their blood. So to conclude, we know that diabetes is becoming very common, much more common globally. It's also clear that diet is important at any time in our life, but the diet that we experience and are exposed to as a growing fetus may be particularly important because of the long-term consequences on our health. And because we're now starting to understand how diet during early life impacts on our long-term risk of developing type 2 diabetes, we can really start thinking about ways of how we go about preventing it or at least treating it. Thank you very much.
That's great. Thank you very much, Sue. That's a really interesting presentation. So now to our final speaker, we have Professor Claire Hughes, who's from the Centre for Family Research.
So thank you for the two really interesting talks. As Craig mentioned, the reproduction SRI has as its aim interdisciplinarity, and I'm going to show you some of that now by moving from biology to behaviour. Now, I've chosen the title Worrying in the Wings because I think that for new parents, there can be anxieties that are a little bit akin to stage fright. So you're stepping onto the parental stage, taking on a new role. And in today's world, we tend to grow up in relatively small families and we're geographically dispersed. So for many people, you come to this new role with almost no opportunities for rehearsal. And given the use of social media, there's almost definitely an audience. So there's a sense of worrying as you're about to step on and become a parent. Now, of course, there was a time when severe anxieties about becoming a parent were really much more real. So for those of you that have been picking up on non-pandemic related news recently, what you can see here is a birthing girdle that was probably produced by English monks in the 15th century. So the plague devastated Europe's population in the 1300s. So there's this post-Black Death depopulation. And so that led to a rise in pregnancy-related medical texts and remedies. And there were remedies and prayers that are actually, they're in the calligraphy in this. And it was in the news because a Cambridge postdoc, Sarah Fidiment, showed that this birthing girdle contained traces of honey, milk, eggs, cereals, all part of the magic, if you like, but also human proteins specific to cervical vaginal fluid. So it's a historical object that includes direct evidence as to its use. So I just thought that was an interesting kind of aside, but I want to really today bring us back to the modern world. And as my background, I'll start with some contrasts across time and place about what it's like for parents as they make that transition. And then I'll focus a little on what we know about postnatal depression and birth trauma. And I'll be talking about findings from an ESRC-funded study, the New Fathers and Mothers study, which is an international study that involved collaborators in New York and in the Netherlands. And for those of you who may have to go off and feed your own babies, here's the headline news. Birth trauma affects dads too, and toddler adjustment is related to prenatal well-being in both parents. But if you're able to stay, I'll try and explain a little bit about why that might be. Okay, can't I? Okay. So whereas mortality was as much as 1 in 100 in the medieval times, so there really was a good reason for feeling anxious about giving birth. Modern medicine has made giving birth a much safer procedure, but even in the last 50 odd years, you can see that globally, so the green pattern is the global trend, there's been a very significant drop in infant mortality. It's halved from 1990 to 2015, but it remains 10 times more common in sub-Saharan Africa than in Western countries. So alongside the changes in, I think I've skipped a slide, yeah. Changes in mortality, other trends, we're actually delaying the transition to parenthood as well. So you can see across, this is a number of different European countries, but the trend is actually global. So we're becoming parents for the first time later in life than we were before. And alongside that, and perhaps related, the number of minutes spent in childcare have dramatically increased, importantly for both mothers and fathers. So in one analysis of 11 rich countries, the estimate was that in 1965, mothers spent an average of 54 minutes a day caring for their children, but 104 minutes in 2012. Now, men do less than women, that has to be said, but they do far more than men in the past. So their childcaring time has jumped from 16 minutes a day in 1965 to 59 minutes a day in 2012. And there's probably a range of things that underpin that. So shifting attitudes to gender norms, the fact that you've got dual earner households, there's cohabitation before delayed parenthood, so that men are learning to pitch in much more than they might have done before. At the same time, this graph shows there's also marked contrast, not just over time, but across place, so differences in different countries. So you'll see that Denmark needs its own scale because the average has risen so steeply for both mums and dads, I mean, most significantly mums. And interestingly, countries like France, there's been no sign of an increase over that period at all. One reason for that might be that in France is one of the countries that puts a significant state subsidy for childcare. And in another study of 22 OECD countries, Glass and colleagues showed that there's something called the happiness deficit, that basically, on average, parents are a little bit less happy than non-parents. But the size of that happiness deficit is really systematically related to the extent to which society shows support for parents. So in countries where childcare doesn't cost very much, so around 6% or so, which would be what it would be in the Netherlands, for example, there is no difference. And then in countries where childcare costs about 25% of the median wage, and that would be the UK, there's a much clearer happiness deficit. So there are effects of time and there are also effects of place. And for some, the happiness deficit actually turns into something much more serious, postnatal depression. So this is a period of 2 weeks or more of feeling anxious or irritable, not being able to sleep even when your baby is sleeping, perhaps having poor appetite or comfort eating, so disturbances of appetite, feeling guilty, negative thoughts, just a lack of pleasure in life, feeling that life isn't worth living, and then finding it hard to look after yourself and your baby. So I think postnatal depression is something we've all heard of, but what may be less talked about is postpartum trauma or post-traumatic stress disorder. And this is experienced about 9% of women. So it's not much lower than the average percentage of women that are experiencing postnatal depression. And interestingly, a traumatic birth can be one of the most common causes for PTSD. And this is because whereas major traumatic events like being in a tsunami or being in a major car crash or something like that, once you're out of the event, you can kind of forget it and move on because your everyday life is so very different. But when you're caring for a baby, then every day you're getting a reminder of that difficult experience. So it's really difficult to move on. And in some cases, the traumas are very medical, so prolapsed cord or maternal complications needing delivery via extractor or forceps or needing to stay in NICU. But sometimes as well, it can be just more a sense of feeling powerless or not getting enough communication or support. So while we might not be able to do much to reduce complicated births, except perhaps to combat obesity, which, as you've heard, is a really significant risk in pregnancy, we could be thinking about how do we communicate with parents giving birth and how do we make them feel more supported. Interestingly, the fear of giving birth has become so common that in 2000, the term tuckophobia was coined to describe it. So you can have women who are approaching birth with negative expectations, and then their natural birthing ability is inhibited by fear, and that can make them distrustful of medical intervention, and they can end up having a very intrusive birth experience, and that gets shared in the media, and so you get this cascade of fear that gets spread. And perhaps the most famous celebrity is Helen Mirren, who apparently was so traumatized as a teenager by watching a video of a very graphic video of people giving birth that she never became a mother. That's an extreme example, but actually it is more common than one might think. In dads, it's not just the fear of actually giving birth that is there. There can be a fear for partners as well. So up to 50% of dads can show quite severe anxiety in the perinatal period, particularly around the time of birth. And if you look at the predictors that I've put up here, so some of them is to do with lower education or income, work-family conflicts. So these are people who may be under a lot of stress, not having a lot of support in general. Having a partner who's anxious or depressed, you can see how that could be contagious, if you like. But the one I was struck by was that being present at a previous birth is a predictor of perinatal anxiety. So that suggests that we're really not doing enough to help dads through the process. And unfortunately, this anxiety isn't just a transitory thing. It can have significant consequences. That said, of course, the strongest predictor of postnatal depression, or PND, is antenatal depression. So I've used this image of a river flowing just so that as a kind of metaphor, because if the waters, the emotional waters are already choppy, then giving birth can create white water, if you like. So if things were peaceful beforehand, then actually you're more likely to make that transition without things getting too traumatic. And just under 40% of mothers with postnatal depression showed antenatal depression as well. So it really is a case of you can tell in advance to a substantial degree which women are likely to show postnatal depression. And so you really could be getting the intervention and support in earlier. Okay, so that's the background. Now I'd like to tell you a little bit about the New Fathers and Mothers study. It had 4 different waves, but I'm just going to be talking about the first 2 waves. So when we recruited the families and did the first home visit in the 3rd trimester of pregnancy, so around 36 weeks, and then when we saw them again at home at 4 months. So there were about 447 first-time expectant couples, of whom about half were in the UK, and I mentioned the other half was split between the USA and the Netherlands, and about 1 in 3 of these expectant mothers reported 3 or more symptoms of anxiety or depression. Okay, and this is just to show you that of the 221 in the UK who we were able to recruit, 199 agreed to the home visit at 4 months. So we were able to retain 92%, and that's important because obviously a major life event like giving birth could really put people off the idea of taking part in research. 5 of those were because they were ineligible, and that will have been because there was not a safe delivery of a healthy baby, and for ethical reasons we weren't allowed to go to those families. So our results are perhaps somewhat conservative because those who really had a properly traumatic birth experience weren't in the study. Okay, so I'm now going to show you some models, and I just want to walk you through the key findings. Don't worry too much about the models looking a bit scary. So if you look at the blue lines here, what you can see is that for both mums at the top and dads at the bottom, there's substantial stability from prenatal to postnatal in levels of distress. So antenatal depression explained about a quarter of the variation in postnatal depression. And that's even when we controlled for pre-pregnancy history of depression and anxiety. We also showed that within couples, there was a significant within couple similarity in levels of distress, both pre and post birth. So there is some extent to which couples are sharing these feelings of distress and perhaps an element of contagion as well. And then independent of what that stability over time, the birth experience, having a difficult birth experience, also predicted postnatal depression. So our parents who'd had a C-section were significantly more likely to be reporting postnatal depression at 4 months. And then looking at what was happening from antenatal to the birth experience, as predicted in that model that I showed you with the tocophobia, those parents who were experiencing anxiety or depression before the birth were more likely to have a difficult birth experience. And this all matters for children because it turns out that when we follow the children up, remember I showed you there were 4 time points and we kept going until the children were 2. What we found was that the ratings of adjustment problems in toddlerhood, and by adjustment problems, I mean both kind of acting out, being disruptive, aggressive, inattentive, restless, but also sort of internalizing problems, so showing anxiety, fearfulness, distress, high levels of sadness. Each of those was independently related to parents' prenatal well-being, even when you took in parents' concurrent well-being. And interestingly, whereas for the acting out, the disruptive behavior, that was a direct link, for toddler sadness and anxiety, that effect was explained by couple conflict. So the couples are arguing, and that is contributing to the child feeling anxious and fearful. And that's explaining some of the link between the prenatal well-being and the child problems. One of the things we were able to do in this study was examine variability, because of course there's the average, but there's an awful lot of individual differences. And as you can see from these slopes here, these show well-being over time, levels of problems, anxiety and depression symptoms. And what we found was that for both mums and dads, that variability was to a large extent explained by levels of social support. But the nature of that social support differed for mums and dads. So for mums, it was friends. Having good friends meant that they were much less likely to be reporting problems of anxiety, depression at 2 than they were prenatally. Whereas for dads, the key source of support was family rather than friends. So to conclude, what I think the important take-home message is that there are striking similarities between mothers and fathers, both in the persistence of distress across the transition to parenthood and in the experience and emotional impact of a difficult birth, as well as in links between well-being and toddler adjustment. But there are both similarities and differences with respect to buffering effects of social support. And looking forward and thinking about what all this might mean for practice, I've been told that the Rosie Maternity Hospital at Addenbrooke's has, because of this study, started to give birth partners name badges to facilitate inclusion in decision-making process. Now that might seem like a tiny thing, but actually if you know somebody's name, if it's there on a badge, then you are more likely to talk to them and involve them in a discussion, and it makes them feel like they're part of the team rather than just kind of hovering and overlooked on the sidelines. Addenbrooke's is also piloting peer support groups for fathers in their neonatal intensive care unit. And then in another recent study, it's been shown that the impact of breastfeeding interventions is increased, it's more effective if partners are given information as well. And the NHS has also just recently created something called DadPad, which is like a kind of accessible set of guidance notes that's aimed specifically at dads, helping them through that transition to parenthood. So hopefully in future years, parents will have a much easier time across this transition.
Okay, that's great. Thank you very much, Claire. And thank you to all our speakers as well for sticking to time. It's really helpful. So just a reminder, if you have any questions for our speakers, you can drop them into the Q&A. If it's directed at a particular speaker, if you could just let us know kind of who it's directed at. And I will kind of read out some of the questions and ask our speakers to respond. So to start with, I think this is a question for Dino. So Dino, kind of given that that mitochondria are inherited from the mother, how are the harmful changes in the mitochondria of the sperm cell passed on to the offspring?
Hi, can you hear me? Yeah.
Yes.
Right. Well, thank you for that question. It's very insightful. So what happens in problem pregnancies is that all cells get affected during development in the developing embryo. So on the one hand, we have harmful changes, which are called epigenetic marks, if you like in the sperm as well as in other cells. But on the other hand, the mitochondria within cells develop a protective effect against this problem. Now, precisely because we only inherit the most mitochondria from our mothers, that transmission of the protective trait can be transmitted across the maternal line. On the other hand, the cardiotoxic trait, if you like, the problem that generates an increased risk of heart disease, can be transmitted only via the sperm.
That's great. Thanks, Dino. So we have a couple of questions now for Sue. So the first question is, assuming survival without major negative immediate physical impact, are there long-term health implications of extremely premature birth, so 24 to 26 weeks, which is automatically an extremely low birth weight?
Yep, so that's an excellent question. And Dino will probably want to add in something to my response as well. So clearly extreme premature babies have only been surviving probably since about the late 1970s. So those populations are still relatively young, but there is some evidence to suggest that being born premature also independently increases risk of heart disease and diabetes. So I say increasing risk doesn't cause it. Now, yes, premature babies are small, but it's probably not being small per se that's the problem. It's being small because they're small for your relative age of gestation. So if you're small but appropriately grown for how long you've been a developing fetus, you may be okay. And so at any time point during pregnancy, if you're small for your gestational age, as we call it, then that may be increasing risk. In relation to prematurity, there's also an additional factor that most premature babies the mothers are given steroids and glucocorticoids to aid survival of the baby, because you need to mature the lungs, and that's absolutely essential to promote survival. But there's also some evidence that exposure to high levels of glucocorticoids themselves can also increase risk of heart disease and type 2 diabetes. So whether it's the prematurity per se, probably not, but it may be a combination of often babies who are premature are also small for their gestational age, and there may be an additional component related to the glucocorticoids. And so Dino's done quite a bit of work on the glucocorticoids. He may want to add on to my answer there in relation to glucocorticoids.
Yeah, I don't want to add much more. I mean, Sue has explained it beautifully, but it is true. This is a field of looking at the biology of ex-preterm infants or ex-preterm adult men and women. And there is quite a lot of evidence that if you were preterm, you are at greater risk, as Sue explained, of cardiometabolic disease. So high blood pressure, for instance, or a predisposition to diabetes. And the reason is because towards the end of pregnancy, towards the end of gestation, the unborn child is exposed to a number of maturing hormones that preterm infants miss. And that may have something to do with their increased risk of diseases later in life. So clearly this is, as we discussed, a gene-environment interaction. So the thing to do is if there are men and women who are born preterm, is obviously to try and maintain a healthy weight, to try and avoid smoking, and to try and avoid a sedentary life, because this is only a risk of future cardiometabolic disease. It's not a cause. And that's very important to emphasize.
Great, thanks, Dino. And a second question. So if low birth weight and famine during pregnancy increases the risk of diabetes, why is the prevalence of diabetes increasing so much now when people are eating more during pregnancy than in previous generations?
Yep, so that's also an excellent question. I can answer that twofold as well. So we know that obesity in itself is a risk factor for type 2 diabetes and heart disease. Obesity makes you more what we call insulin resistant, so your insulin doesn't work as well. And so obesity as an adult increases your risk of type 2 diabetes. Now, in addition to that, you may have noticed it on one of my slides, there's more and more evidence now to suggest that actually exposure to an obesogenic environment during fetal life causes similar impacts on our long-term health, as does exposure to high glucose. Now, in relation to that, that may be twofold. We also have to consider that what the mother eats is not the same as what the fetus sees. So obesity during pregnancy is associated in itself with increased risk of low birth weight birth as well as high birth weight, probably because maternal obesity is impacting on the function of the placenta. So it's almost like you have famine in the face of plenty, in terms of you may have a well-nourished mother, but if you have a poorly functioning placenta because of increased adiposity in the mother, for example, that will still lead to a low birth weight baby. But equally, as I said, exposure to high glucose and inappropriate overgrowth of the fetus will also increase risk of those same conditions. And actually, if you look in populations where there's lots of maternal obesity and lots of gestational diabetes, actually what you see is a U-shaped relationship between birth weight and type 2 diabetes. In those initial Hertfordshire cohorts, where obviously individuals born in the 1910s, there was very little maternal obesity and gestational diabetes back then 100 years ago. So what you didn't see in those populations were those very, very high birth weight babies, which would also have an increased risk of the same cardiometabolic outcomes.
That's great, thanks, Sue. So now a question for Claire about postnatal depression. So what support is there available to help reduce the risk of postnatal depression in women?
So Craig, I'm glad you phrased the question that way, because I think that's the important strategy. It's to reduce the risk rather than helping mothers once they are depressed, although of course we need to be doing that as well. So in the slide where I was showing the childcare happiness deficit, the extent to which, if childcare is really expensive, being a parent is kind of associated with a greater deficit. There are other initiatives that other countries have done that I think would be really nice if we could follow. So in Stockholm, I know that if you're traveling on public transport with a buggy, you travel for free. And so, of course, that makes it a whole lot easier for people to visit their families and friends and get out and about and do things. It's sending out a signal as well that a society, the parents of young children are valued and that they're, that you're trying to help. In Belgium, I believe that as part of your maternity leave, for the first 6 months of life, you get funding for a cleaner to come and clean your house. And that's really sending out a signal that, you know, you're doing a great job as a mom, and that's what your primary job is there, is to raise your child, and, you know, other people can help keep your house a little bit clean. So there are simple things like that we can do. Obviously, I would be a big advocate for increasing paternal leave, paternity leave, so that women are not alone in that postnatal period, making it, just normalizing it, because sometimes even when there are the schemes, there seems to be a certain amount of stigma. I do hope that that's something that the pandemic may have changed, that so many dads have been living at home and working at home, that perhaps the idea of taking time off and working from home and that may be something going forwards. Of course, in the pandemic, there's been extra problems because all the normal support groups that there might be are a lot harder. That said, I mean, we are fortunate to live in a kind of age of the internet, so that I know from the mothers in my study that a lot of them talked about having WhatsApp groups with various people that they really only knew because they were going through the same process at the same time, so that if they were up in the middle of the night with a crying baby, they could see if anybody else was up as well, and kind of looking out for each other. So some of it can be grassroots. And then the other point to say is that, of course, postnatal depression, like any other kind of depression, can range from being relatively mild and something that maybe, you know, a trip to the hairdressers or something like that could be enough to kind of lift your spirits, to something that's really, well, postpartum psychosis, where you're actually a danger to either to yourself or to your baby. And so in those very extreme cases, what happens, and I don't know whether we have enough places for this, is mother-baby units, where the mother and the baby are supported in hospital for a period of around 6 weeks, where they basically get a little bit of apprenticeship and support in reading their baby's signals and in recognizing that they're doing a great job. But you're right that it ought to be reducing the risk of postnatal depression rather than trying to deal with it once it's there.
Thanks. And have there been any studies that have looked at the outcomes for pregnant women who access support prior to giving birth, such as kind of counselling for depression?
I'm sure there have been. I can't think of any off the top of my head. I think most pregnant women do an awful lot of checking up of what is out there. But I mean, it's certainly the case that interventions matter, not just in terms of what you deliver, but when you deliver. And getting in early with an intervention can really help. So for parenting support, remember that I talked a little bit about how this can affect toddlers and their adjustment problems. Once you have a child, there can be a real stigma around asking for help, because it's almost admitting that you're struggling and that you're failing and that you're finding it really hard. Whereas if you could go to get some parenting support before the baby's even arrived, if you mentally can get yourself past the worry about giving birth in order to imagine yourself as a parent, then of course there is no stigma. Nobody knows whether you're going to be a great parent or not. And also perhaps you're just less busy because you're not having to deal with all the stuff that comes with looking after a child and fitting in around their routine and everything else. So having interventions proactively to build up that parental confidence before the birth, I think would also be a really good strategy.
Thanks, Claire. And actually a question that's just come in. Should we take account of fear of birth in sex education? So when showing birth videos, etc.
I'm not sure how much of that. So Helen Mirren is of a certain age. So I imagine that probably the videos she watched were a deal more graphic than they would be now. I think the emphasis is very much more on the whole kind of relationship building and assertiveness and everything else. I don't know that graphic videos get shown these days, but it's just to show you that can be traumatic. I think much more damage is done through social media, where people. So I mean, I have 3 children and I had 3 easy births, and I really felt that I could not talk about my births in those postnatal circles. because you want the people who've got trauma to get off their chests to be able to talk. But of course, that's the way in which people get a skewed picture of what giving birth is like, because the stories you hear are the horror stories. You don't hear the fairly straightforward stories. So maybe we need a bit of a counterpoint. So one of the most useful things that somebody ever said to me was that labor is called labor because it's hard work, you know, but it's productive. You're doing something, the most important job you've ever done, but not thinking about it as something that is being done to you and that you're somehow going through something. This is you giving birth. I think if mothers can see themselves in that way, then they will think of themselves as amazing in just doing it.
That's great, thanks. So now a question for actually all of the panelists. So how do we strike the right balance between encouraging parents, so mainly mothers, to adopt behaviours that may benefit their unborn children and not blaming them for any adverse outcomes further down the line? Who would like to take that one first? Shall we go in order that you went? Dino, do you want to go first?
Oh, I mean, it's a very difficult question to answer, isn't it? Because we're only just beginning to disentangle and pick at the exact mechanisms by which we can, you know, inherit risk of disease and then as well as transmit it onto the future generation. But I think, you know, all we can say is that, of course, our health is important for our children and also for their children's children. So, you know, how do we strike a balance? I guess as we try to maintain as healthy of a life as we can, you know, try to achieve. I think because now we know it does have some really long-term repercussions, you know, across generations.
Thanks, Sue.
Yeah, I mean, I agree with everything that Dino's just said, but I also want to add to that it's not all about the mums in terms of what the dad is doing around the time of conception in terms of his lifestyle and diet. There's also growing evidence to show that that can impact on the long-term health of the baby. So I think we do have to take the focus away from it all being just on the mother, and the dad is important as well.
Okay, thanks, Claire.
Yeah, so I think one of the positive directions would be to change the discourse around things like addictions. So, and to enable somebody to come and ask for help if they have an addiction, whether that's with drink or smoking. I mean, I'm always struck by the fact that I think it's about 17% of women of childbearing age who smoke these days, and only about half of them seem to give up when they're pregnant. So, and that is because if you're a smoker, you're probably addicted to smoking, and the whole feelings of morning sickness and everything may make it really hard to give up the nicotine. But if you get rid of the discourse of blame and stigma, then people are much more likely to come forward and ask for help with how do they stop smoking, how do they stop drinking. And then the other thing is, maybe it's just the African proverb that it takes a village to raise a child, and that actually the way in which a child turns out, it's not all about the parent. There are so many other things that go in there too, and that parents shouldn't feel that they're always the ones that are culpable.
That's great, thanks. So now, just before we finish, I'd like to ask one kind of final question to each of the panelists. So if tomorrow morning your next door neighbours told you that they were pregnant and going to have a baby, what advice could you give them to give their baby the best chance of having a healthy life? Actually, Claire, do you want to start there?
Well, first of all, I'd congratulate them and make sure that, you know, that they understand that this is really exciting news, and it's exciting not just for the parent, but for everybody around. A new birth has a ripple effect, and lots of people ought to feel that kind of joy. And then just being kind to yourself and not seeing all the different ways in which you can fail. So one of the good pieces of advice that I was given when I was pregnant was, it's a bit like the parental advice, choose your battles. It's about thinking about which things are most important to you try and get those things right. And don't worry about if you're not hitting all the targets for the things that don't matter so much to you, because boy, oh boy, can you be given lots of advice about the many different things that you can and should be doing. So if you think that food is really important, meal times are really important, then put your energies there. But if you think that reading to your child is super important, then focus there. But don't try and be all things to all people, because nobody can be.
Thanks, Claire. Sue?
Yeah, so firstly, I would congratulate them, tell them to enjoy it. It's a special time in their lives. Don't put too much pressure on themselves, and reach out for the support that's available, whether it be from your friends, family network, or other support on the wider community that's available. So enjoy it.
Okay, thanks. And lastly, Dino.
Yeah, I would agree with both those comments, and I would also remind ourselves, including them, that maternal stress is a big problem that can also influence the development of your child. So worrying about how much you're eating, or giving up all these things that you enjoyed before getting pregnant, if you like, is making you overstressed, then that can also be problematic. So it's I guess it's more of everything in moderation almost.
That's great. Well, thank you very much for your advice. And so thank you everyone for joining us this evening. And so once again, thank you to our brilliant speakers, to Dino, Sue and Claire. I'd also like to thank Louise Walsh and Christina Rosaic for organising tonight's event. So if you want to find out more about the Reproduction Strategic Research Initiative or our Horizons magazine, there are links in your ticket if you can check those. Don't forget that the Cambridge Festival runs until 4th of April, so there's plenty of time to join in other events. So you can check out the programme online at festival.cam.ac.uk. Before you go, we'd just like to ask you a couple of very quick questions via a Zoom poll, just to give us some feedback about the event. So Sarah, please could you launch the poll? There you are. And once again, thank you very much for joining us this evening. I hope you enjoyed the event, and stay safe. Thank you.